Welcome to our Curious Amalgam, the weekly podcast brought to you by the Antitrust Law section of the American Bar Association. Our Curious Amalgam explores the fascinating and increasingly overlapping world of competition, consumer protection, data protection, and privacy law. Each week, we bring you leading global experts on the most compelling issues of the day. Enjoy the show.
Hello and welcome to our Curious Amalgam, the podcast from the American Bar Association Antitrust Law section. My name is Anora Wang. Today's episode is titled as Who Does Your Doctor Work For? Vertical Integration in Healthcare Provider Market. Joining me today is my co-host Derek Jackson. Hi, Derek.
Hi, Anora.
Derek, what are we discussing today?
So today we're going to talk about vertical integration in the healthcare provider market. For some background, hospitals as well as insurers have been increasingly purchasing physicians' practices, home health providers, and nursing facilities. And this is illustrated by the fact that United Health Group subsidiary Optum is now actually the largest employer of physicians in the country, employing approximately 10% of all physicians. Economic theory suggests that there could be real pro-competitive benefits to this type of integration, but also real risks of anti-competitive effects. And so today we want to talk about that theory and also what the empirical evidence in fact shows.
And who is joining us as a guest to this discussion?
So we're very lucky today to be joined by Zack Cooper. Zack is a faculty member at Yale University, and he has appointments at the Yale School of Public Health and the Department of Economics. He serves as the Director of Health Policy at Yale's Tobin Center for Economic Policy, and is also a senior consultant for Charles River Associates. And in Zack's academic work, he has examined, among other things, how rising healthcare spending impacts the wider U.S. economy, the drivers of variation and growth in U.S. health spending, and the effect of competition in the hospital and insurance markets. So he's really the perfect guest for today's topic. Zack holds a Ph.D. in economics from the London School of Economics, and specifically of note for today, he is the co-author of a recent published paper on the competitive effects of hospital acquisition of physicians. So we're very lucky to get his insights on this topic.
Welcome, Zack.
Well, thank you. Thank you for having me. Where did the title come from? The Curious Amalgam. Did you guys inherit it? Did you name it?
We did. There was a debate in behind that you don't want to get into a discussion
okay.
too.
So we'll leave it to vertical integration then.
Right.
Right.
And I believe it refers to the fact that the ABA Antitrust Law section covers antitrust, but also data privacy and consumer protection issues. And so all those together make our nice curious amalgam.
There we go. Okay.
And for the record,
it's like the FTC.
Yeah, for the record, when we first discussed this title, I had a no in the vote because I felt like amalgam reminds people about their dental visits, which is not that pleasant. But I guess it's fitting for today's discussion. We're talking about dental or their physician's visits anyway. So let's kick off the topic.
Totally.
What is the current landscape with respect to vertical integration of physicians' practices in the U.S. healthcare market? And let's start there and what antitrust questions might follow.
Totally. Well, let's maybe zoom back out, right? There's about $1 trillion a year spent on physicians in this country, in the U.S., right? It's about 21% health spending. It's, depending on how you measure it, 4 or 5% of GDP. And so this is a big sector of the overall health system. It's a big sector of the overall economy. And we've really seen, I think, the market for physician services get transformed over the last, I'd say, 2 or so decades. So, we went from this world where, you could think of the physician sector as a bunch of sole proprietors, right? A nice doctor and a shingle and selling their services. And that's just not what the market looks like anymore. So if we sort of zoom back out, back in sort of 2000, my guess is you probably have, 10, 20% of physicians employed by a hospital. Right today, you're seeing on the order of 50% who are employed by a hospital, who are then sort of vertically integrated. Although we should talk a little bit about how we're going to define vertical integration, because it's a little, I actually think the nuances are important. I think the boundary between horizontal and vertical is actually getting pretty murky. So half of them are working for hospitals, And then if we look on the physician side, Derek, you said it, right? The largest insurer, and I actually don't think we should really call them an insurer anymore. It's sort of like a healthcare conglomerate. United Health Group is largely the biggest owner of physician practices. So they're going to employ something on the order of 100, or excuse me, of 10,000 directly employed, probably about 100,000 in total, which is a big chunk, right? So they're going to have some sort of contractual or ownership relationship with nearly 10% of the physician sector. So this is a pretty big reshaping of a pretty big chunk of the economy. So then, Nora, if you want, we can get into what we think are the competitive concerns, but I'll let you, tell me where you want to go.
Yeah, and Zach, I want to actually circle back to one thing you said there, because I think it might be worth talking about before we jump into the antitrust concerns. I think it's easy to think of the transformation you just described as a classic example of vertical integration, but you mentioned, the vertical horizontal distinction isn't necessarily so clear, especially in this market. And so how do we think about the way the market has changed in terms of those labels, or are those even useful labels to use in this context?
Well, I think in general in antitrust, we're starting to see a sort of blurring between horizontal and vertical. If we look at the last set of guidelines, there you didn't really see the distinction. So let's sort of think about it in the hospital physician space. There are some services where they actually are competitors. So if I need to get infusion, I can get it in a doctor's office, I can get it in a hospital. So in that case, they're sort of in the same market. Now, the flip side is if you're a hospital, you just literally can't function without physicians, right? Physicians define the scope of the care that gets provided. In a sense, they curate demand for patients. They then help inform patients about where they get care, and we can talk a little bit about that in more detail. And then they actually do the caring inside the hospital. So I can't go to a hospital and get surgery without engaging with a physician. So I think that sort of boundary is just like a little blurry. And I think we're actually seeing that similarly on the payer provider side. So I think traditionally, we think obviously payers out there, they're procuring services from providers. Okay, then those coming together, that's, I think, pretty classically vertical. The flip side is it might be that, a payer is thinking less about simply reimbursing for medical care, but think about how you help their policyholders navigate around a very complicated system. And in that case, they could employ physicians who help their policyholders. Well, then, again, it's really sort of, it isn't vertical per se. It's really like part of the production process for a payer. So I think those boundaries, they aren't as, I think, clean as maybe we like think about, or as clean as say like I don't know, Foot Locker merging with the manufacturer of shoes who, integrates vertically with, the people who make the rubber that go on the bottom of the shoes. I think it's much more blurry in the health sector.
Well, it's not as clean or blurry, but vertical versus horizontal is still a useful framework to guide our thinking. So sticking with that framework, what are the theories of harm and what are the theories of efficiencies from the vertical integrations in the context that we're talking about?
Yeah, I mean, so let's start on the hospital physician because I think that's a little cleaner than the payer provider. So on the hospital physician side, I think you're going to have your standard efficiency arguments. One of those, for example, is just the back office staff. It's just literally more efficient for the physician to have his or her back office staff folded in with a hospital that's already pretty darn good at that. There's all of the work with electronic medical records, right? It's pretty expensive for your single-handed primary care physician to get the latest and greatest EMR. And that's going to be something that you really do want to have scale to procure. There are all sorts of benefits when it comes to care coordination potentially. So, one example might be that, I end up in a hospital or I'm going to go to a hospital, but the tests that my primary care physician does are now available to everybody within the health system. So there's less duplication. So it's really around sort of efficiency and I'd say sort of coordination of care. Now, I think the theories of harm, and this is, I think, a place we have to acknowledge the theory on vertical integration is just much more concentrated than horizontal integration. Right? I think we have a very clear set of tools in antitrust to measure horizontal overlap. We have a clear sort of set of theory that allows us to make predictions. You really can from theory, make almost any prediction about vertical integration. But I think the theories of harm, the first is, I think the standard one is going to be foreclosure. Right? There's something that I, as the vertically integrated unit, can do to, Nora, you and I coming together can foreclose or raise the costs to Derek. So in the healthcare sector, what might that look like? If I'm a physician and Anora, you're a hospital, we come together, and what we basically say is, look, like for Derek to either work in your facility, do surgery there, or send his patients to your hospital, he's got to be part of your system, right? And that might literally just like raise the costs for Derek and Derek's patients of getting care there. It's just a very, very simple rivals and foreclosure story. The other way you want to think about it is access to patients and access to patient volume. So I have a paper, and this is several years ago, with my colleague Fiona Scott Morton, who's actually also a CRA associate. And what we look at is how people consume lower limb MRI scans, right? So this is, you go on a ski trip, you hurt your knee, you get a scan. And often in healthcare, we talk about shoppability, the extent to which this is sort of a commoditized product. And in many ways, MRI scans are probably the most commoditized product in healthcare outside of, say, generics that there is, right? 2 MRIs are ostensibly the same. And what we found, which is pretty wild, is patients are leaving huge amounts of money on the table, right? That the average person drives by, I think, 6 places between their home and where they get care that are lower cost than where they actually ended up receiving their care. And so we're curious, like, why is this? Why are patients doing it? And it isn't the usual things we think define demand, right? It isn't usually a travel distance. Like usually the place closest to their home is cheaper than where they get care. So they're not having to travel farther to do it. We don't think really quality varies. What it ends up being is the referring physician. Right? Patients just sort of listen to their doctors about where they get care. And so I think part of what's happening is hospitals are buying up physicians across the country, and that sort of limits the cross-price elasticity. If I'm a patient, my doctor now goes and works for a hospital, it's pretty hard for me to stay away from that hospital, and that just sort of limits choice. So I think that's the sort of first flavor of harm. The second is a lot more subtle, but it's basically the nature of the bargaining between hospitals, insurers, and physicians. So before, if you and I, Nora, were separate, I go to the insurer, I try to negotiate a contract, and they sort of look at me and they say, well, you're not that big a physician practice, here are your rates, and they're going to make it sort of take it or leave it offer. Once I become vertically integrated, it's not that simple, right? They're negotiating over you and I together, and I actually benefit from your bargaining heft. And so basically you'd think like when, if I'm a very important physician, in theory, that's going to make you as a hospital able to negotiate higher rates. Conversely, if you're a very dominant hospital, I as a physician am going to be able to sort of ride in the jet stream of those negotiations. And so, what we did in this paper is try to spell out very, very clearly the theories of harm, because I think, and we'll talk about it in a second, there are lots of ways that vertical integration could lower or raise health spending. And on the raising side, it isn't from a lessening of competition. We'll chat about it. But we want to say, okay, what are the specific avenues through which these sorts of transactions could reshape the market in ways that have less competition and in turn could lead to prices going up.
I think that's really interesting on the hospital side, and I think we'll talk about the insurer side in a minute. Yeah. But maybe while we're talking hospitals and you sort of laid out the theory, you've done a study on this and looked at the empirical evidence. Do you want to just give us at a high level what you found in that paper?
Yeah. So let's maybe take a step back. So I think there are a handful of studies that show pretty clearly when hospitals and physicians come together, the negotiated prices that each party is going to see go up. And I think we knew that. Now, the question is why, right? And it turns out like it could be that these entities are getting better. And because they're getting better, we're willing to pay more for them. The other thing is, for a lot of these, and I don't think these are antitrust issues. The Medicare program, for example, pays physicians more, believe it or not, if they're working in a hospital-owned practice. So if you're an oncologist and you're going to infuse chemotherapy drugs. You're going to get, I don't know, $2,000, let's say, Derek, if you own your own practice. You're going to actually get $4,000 if you're in a practice owned by a hospital. And unsurprisingly, like, what does that do? It creates a huge incentive for hospitals to go buying up doctors' practices. It raises the cost of care. But that's not competitive harm, right? That's just a sort of idiosyncrasy in how the Medicare program pays. And so what we tried to do is say, okay, well, what do we actually see when we unpack literature? So the first thing we see is pretty big price increases. So when hospitals buy physician practices, and we're looking at obstetricians, so baby deliveries, if you're privately insured, like that's the highest volume inpatient service. We're going to see hospital prices go up by about 4% when they buy physician practices. And we're going to see the physician prices go up by about 15 to 16%. So pretty big jumps. We have really good pricing data. So we're using, in this case, actually data, it's public from United Health Group. So we can see sort of all the prices that they negotiate with payers across the country. The question is, like, what's driving those price increases? And what we try to do is first rule out quality changes. And so we have a bunch of quality measures for baby deliveries, and we actually don't see any of that really shifting. So we sort of say, okay, prices are going up. It doesn't appear to be quality. So what else could it be? And we're going to sort of look at the rock from a bunch of different directions, sort of rotate it around and see if we can see evidence consistent with lessening competition. So the first thing we see is that if Anora buys a doctor's practice that has more scope to change their referrals, she sees bigger price increases, right? So it turns out, a lot of the physicians who get vertically integrated are already doing a bunch of their care at the hospital where the ownership change happens. That actually doesn't really lead to price increases. Like, they're already there. There's not any sort of change in the market. But for the transactions where they were nearby, they could shift their volume, but they're already sending patients to somewhere else. Those sorts of transactions, those really lead to pretty sizable pricing increases for the hospital. So we see that. We think that's evidence, again, of that sort of foreclosure effect, sort of capturing referrals. Conversely, again, not all mergers lead to physician price increases. But what we see is that when the hospitals that are doing the acquiring have lots of bargaining power, they actually are able to extract pretty large price increases on the physician side, which is consistent with this sort of recapture concept. And then I think my favorite evidence from the paper is we look at physicians who were already integrated in that system. So, Nora's running a hospital. It's a great place. Derek, you're already there. And you guys go out and buy my practice. Well, Derek, your world hasn't shifted, right? You're doing the same care this week that you were doing last week. But we actually see, Derek, that your prices go up. And we think that's pretty consistent with something happening in the bargaining process. And so I think the big takeaway for us is, prices go up a sizable amount. There's some deals that do lead to price increases, but that isn't happening through a lessening of competition. And other deals where we're sort of giving signposts for where you might expect competitive forces to be at play, those tend to also lead to bigger price increases, we think, driven by a lessening of competition.
Maybe this is the point to get to the other side of things, which is the theoretical efficiencies from vertical integration, right? Like, the usual we think includes things like, elimination of double marginalization. You would put it better, but let's go on address those. What are the potential efficiency theoretically, and have you seen any of that in your empirical evidence?
So we don't see a whole lot of it. So, what could you sort of see in theory, right? There's some double marginalization, right? Maybe some like contracting, now the payer, instead of having a contract with both the physician and the hospital, just does one negotiation, and maybe that sort of lowers costs somewhere. That could be baked in there, but we see the prices go up. So there's sort of no evidence of a price drop. I think the big thing that I would think about in this space is, say, maybe there's a reduction in health spending on these people. Like, there are tests that before were getting performed outside of the hospital, and now when that pair comes together, they're not doing, say, duplication. We just didn't really see evidence of that. And we also didn't really see any evidence of quality improvements. So I think it isn't that there aren't practices that potentially are having some efficiency gains. But I think on average, we certainly don't see that. Now, that's in part why, if all of us were reviewing a specific transaction, we'd say, look, like there's 50,000-foot evidence, and we should understand that and understand the theory. It sort of tells us where to look. And every transaction should be analyzed in a sense on its own to see if it's going to produce, I think specific, efficiency gains. But, at 50,000 feet, we didn't really see evidence of merger efficiencies. And that's, look, I think certainly in the healthcare sector, whether that's horizontal integration, two hospitals coming together, or in this case, vertical integration between hospitals and physicians, there really isn't a great deal of evidence of efficiency gains. I think the best evidence I've seen is sometimes there's better negotiations with downstream suppliers, and a little more sort of harmonization of things like the implants that doctors use. So, for example, if you're a orthopedic practice, one of the things that often is a bit of a pain is when each person's using a different joint. So you got to bring in something from Stryker and something from another manufacturer. Sometimes those, there's just more sort of alignment around one, and that can bring some gains, but we don't really see much evidence there.
So I think it might be interesting to talk a little bit as well about insurer or payer acquisitions. We sort of mentioned hospital acquisitions have grown to be, now almost 50% of physicians are with a hospital-owned practice. But obviously, with United owning 10%, there's been a lot of growth in that area. So what are the issues there? How do they compare to, these transactions in the hospital context, and how are they different?
Yeah, so I think these deals are fascinating. And I think the theory here is fascinating. I think it's actually really clear where some of the efficiencies could come in, particularly from the policyholder or patient's perspective. I think the theories of harm are also, pretty interesting. I'm actually doing some work with the Federal Trade Commission. So they launched I guess they call it a 6B subpoena, where they can subpoena a bunch of data and use it to sort of fact find about what's happening. They did it in, I think it was like 2000, sort of 5, 6, 7, 8. They did a bunch of hospital merger retrospectives. And now what we're trying to do is do something similar here on the physician payer space, and see if we can really sort of understand what's happening. So let's think about the benefits. And I think there it actually can be pretty clear. So, I gave the example of some of the principal agent problems we see in the physician sector, right? That I just, as a patient, don't really know where to get care. And often we see, if I'm going to a hospital or a physician that's vertically integrated, owned by a hospital, they help me get care in that hospital. And that actually can increase my spending. So MRIs cost about double when they're performed in a hospital setting. And the ones who send you to a hospital to get a hospital-based MRI, it's vertically integrated physicians. So in theory, if you say, look, we're going to align the incentives of your physician, in some ways with you and with your money, your payer, they may make different referrals. So they may choose to get you care that's more cost effective, right? They may say, look, if there's two MRI scans out there, two places to get it, we're going to send you to the cheaper location, right? So that could be one. It might be they use a different form of contracting. So, right now, often we have these fee-for-service contracts where, Derek, you as my physician are going to get more the more you sort of see me and the more that gets done. It might be that when the payer owns me, you just change the nature of that contract altogether. So I think the best example here is a study at the University of Chicago looking at these very, very sick patients. And these are folks who are spending $50,000, $60,000, $100,000 a year. And what we see is, if you give them their own basically concierge physician, these are often patients on Medicaid, but if you give them a physician who's really got a small panel who just sort of follows them around, you can save tens of thousands of dollars a year. And it might be in that circumstance, you employ a physician and you say, look, we've got these really, I'm CVS Aetna, or I'm Humana or United. I've got these very expensive patients. I just employ physicians to, in a sense, follow these folks around and keep them out of the hospital, right? You can imagine real savings. And those real savings get passed along to the consumers in the form of lower premiums. So I think that's there. So that I think those are the gains. The competitive harm, I think, is also pretty interesting and pretty subtle potentially. So, one might be, and it gets back to the sort of question of raising rivals. So if I'm a payer, Derek and Anora, you're both providers, I might say, Derek, come work with me. I'm going to give you a very preferred rate, and I'm going to lower the rates for Anora a lot. I'm just going to say if my patients go to her, I'm going to, basically sort of, take it or leave it contract with a hugely low reimbursement. Now, I think that's sort of debatable whether that's selective contracting or competitive harm. Now, if I sort of say to Anora, the only way in a market with two providers for you to get any business, if I'm a powerful insurer, is to see my patients, I'm going to pay you low rates, so I sort of force you to basically sell your practice to me. Well, then I think we're drifting more into sort of competitive harm territory. So I think there it really depends on my upstream negotiating power as a physician or as an insurer, how much bargaining, how much market share I have in that area. There's foreclosure, right? I might just say, look, like Derek, I own Derek's practice. I'm going to make you out of network, Anora, and I'm going to just make it very, very hard for you to see patients, right? That we think is pretty challenging. And I think the other might be just simply like I, as the insurance company, own all the physicians. And so it becomes very hard for you to buy an insurance product that doesn't, from somebody else, because it doesn't include the physicians in your area. Now, I don't think we're anywhere near that, given the sort of scale of physician acquisitions we've seen. But I think those are the sort of theories of competitive harm. The other, and it's worth mentioning because I think, we've seen it a lot. I was down testifying on the Hill, I think, what was this, December. Got a ton of questions about it, and I think it's worth talking about. For very
Those are
good reasons.
December 2025, right?
Yeah, December
We're going to
2025.
provide some links to the audience if they're
It all
interested.
it all blurs together. Right. The days are long, but the years are short. No, I was down there, and one of the questions folks were asking about was payer provider integration in the context of Medicare Advantage. So Medicare Advantage, for folks who don't know out there, is the private sort of arm of the Medicare program where private insurers can sell plans to policyholders. And for very good reasons, we risk adjust those payments. So if I'm an insurer, I get more for covering a patient who I think is an enrollee who's likely to be sick. Otherwise, I do everything I can in my power to get away from them. And what that's led to are, in a sense, accusations that insurers are, shall we say, like ambitious in what they code patients as having. And there's just a lot of debate. If I code everything that's available, is that okay? Is that not okay? And I think this sort of this basically concern when payers start buying providers, are they more likely to do coding that is, in a sense, advantageous to the payer? And there's one great study. It's actually a job market candidate. It's Mariana Guido. She's a Stanford econ PhD student. Has a great paper, a little small, but great paper. It's looking at a bunch of practices that's in Colorado that got bought by a large payer. Sort of saying, what happened? And she can see what happens to their privately insured patients. She can see what happens to the Medicare Advantage patients. And she finds two really interesting effects. Right. One is the physician, the privately insured patients who go there, the folks with employer-sponsored coverage, when they go to a physician who's now owned by an insurer, they end up getting referrals that are much more cost efficient. So they just send them for care at places that are less costly. Okay, that's an efficiency gain. That's really good. The flip side is they also show that in the Medicare Advantage side, the patients treated by that physician end up having much higher risk scores when it comes to insurance. And their insurer, the one that bought those physicians, get much higher payments. Now, it could be that those are appropriate codes. But I think that's, in a sense, the flavor of the debate that we're seeing there.
It's a really interesting point, and maybe a way to kind of, bring this together in the end. it's sort of a mixed bag, right? You mentioned in this study we see evidence of some efficiencies and then also some issues related to the way Medicare Advantage coding works. And in the hospital acquisition space, we see real evidence of higher prices, and some of it may be to competition issues, but some of it may be to other sort of regulatory issues. So what are your sort of takeaways, and how do you think about this in terms of what you would like to see regulators or enforcers focusing on in thinking about these types of transactions?
Yeah, so it's a great question. So first of all, a lot of these deals are very small. So it's two or three doctors getting bought by a hospital or by a payer. So I think this is a whole lot to handle for federal and state regulators. So we're not actually seeing a whole lot of action here. I think for everybody, first, it's going on a deal by deal basis. I think what we did, which I think is hopefully a help to firms thinking about merging and regulators thinking about looking at transactions, is say, look, here's the theory, and here are some predictions. So, if it's a merger where a hospital's buying a physician group that's already sort of doing most of their care at that hospital, right? They're just already there. You're in a pretty competitive market. I don't think that's the kind of transaction we ought to be worried about. Conversely, if they're buying a group of physicians who are doing all of their care, they're sending all their patients to somewhere else, doing all their care somewhere else, and seemingly could switch, well, then we might want to like kick the tires a little bit and see what's going on. The others, I think we flag that, and this gets back to where we started, which is this boundary between vertical and horizontal is actually pretty fuzzy. So if, Derek, you're a physician and Anora's, another physician, I buy Derek. It turns out, I actually am leading to more consolidation in the physician market, depending on how those transactions occur, right? If I sort of bring more physicians under 110, irrespective of whether there's a hospital there, I'm building a bigger footprint. And so I think it's trying to offer a little bit of a theoretical guide to the folks that are out there. I think on the payer provider side, it is fascinating. Like I think we're going to see action in the space, but it's one of these spaces where the theory is pretty ambiguous. There's going to be a whole lot of data that has to be looked at. There are a bunch of different product segments that are going to have different effects, and it's going to be interesting to see how some of the arguments they're made, and the real possibility that I think harm in one part of the market could really be offset by efficiency gains in others. And I think those sorts of transactions are pretty tricky to think about.
Well, this has been a fascinating discussion, and obviously a space that's dynamic and complicated for us to devote more time to discuss, perhaps for another episode. Thank you for guiding us through that. We want to wrap this up usually with a little bit of like a flavor of personal questions, and so that people know you a little better, other than just academia, but also as a person. Could you share with us maybe just one thing that people would not know you if they have just read your paper or worked with you professionally?
What wouldn't they know? I don't think they'd know that I love skydiving. Like that's my sort of secret hobby. So every couple of weeks, in the winter, I'm going down to Florida, and a group of buddies and I get together and jump out of planes and have a great time. So a whole bunch of jumps and a couple parachutes, and that's my sort of I guess my secret identity on the weekends.
Wow. How did you get into skydiving as a hobby?
This is a great story. So Yale has an amazing program called the Eli Whitney Scholars Program, and it's for non-traditional undergrads. And so basically, it's a bunch of folks who didn't go to college for whatever reason, did something interesting, and later in their life decide to go to school. And my best friend was a member of this really high-speed military unit called SEAL Team 6. And he and I had been friends for a long time, and he managed to get himself pretty badly hurt. He got shot, and he struggled, and he was sort of, I think, mid-40s, got back on his feet, and couldn't do his old job well because he has a bit of a hitch in the giddy up, as he likes to say. And he needed to figure out what to do. And I said, why not come to college? Like, you're pretty young, and convince him to come here. And he was very big into skydiving. It was a big part of his old job, but he also had a really big passion for doing it on his own. And when he got through Yale, we were sort of celebrating his graduation. He's like, good news is you got me through here. The bad news is in exchange for dragging me here, I'm gonna teach you to skydive. And so he and a couple of his teammates took me down, and we spent a week jumping together. And then I sort of caught the bug, and now he and I, sort of do it. It's sort of our like buddy escape.
Wow, that's you're learning from the best, I guess, with SEAL Team 6 as your introduction.
It's funny. The first jump. So he chose the two instructors, and they were amazing. They were the guys that he worked with, and it was another one of his teammates. And the two instructors, one of them had 30,000 jumps, the other had 20,000. Jimmy and his teammate each had like 12 or 14,000 jumps. And I remember we're going up, and I'm sweating spinal fluid. Like I literally was like, this is not a good idea. And I look over, and one of the fellows has his cell phone out, and he's like playing like Wordle as the plane's rising. It's like, all right, well, I guess he's not worried. And sure enough, knock on wood, it's been a blast so far.
All
I
right.
have to say, I've been distracted the whole time trying to think of joke about the vertical integration and the vertical. That's the elimination of something.
Exactly. Yeah. Yeah, hopefully not foreclosure.
Right. But one more kind of silly segment we do is what we call Curious Hat.
And now it's time for the Curious Hat.
So the rule of this game is very simple. You give me a number, economist, you can do that, and I'll give you a question corresponding to that number.
Okay, I'm gonna say 3.
3. Is there any particular food item that you dislike intensely?
Ooh, dislike mushrooms. For sure, mushrooms. Although, somebody's trying to convince me otherwise, but I just don't like the texture. So that's sorry to all like the mushroom farmers or mushroom lawyers or fancy cooks out there. That's going to be my one leave it behind. What about you?
There's a huge variety of mushrooms. I'm a mushroom fan, I have to say. I'm a little offended.
You're offended. What did I have? It was like some sort of salt. It was like a mushroom salt that somebody put on to try to convince me. And I will admit this was delightful. But
because that eliminate the texture problem, right?
Exactly. Exactly. So I think that might be the key for me, is like something that eliminates the texture problem.
All right.
Derek, what's yours? Do you have a hard pass?
It's very funny when I tell people this, because I really dislike cherries, which is like a pretty well-liked food universally. But I love mushrooms.
What is the genesis of your cherry frustration?
I think it's something about, and I understand there's a difference between real cherries and sort of the artificial flavor, but sort of when you have those like artificially flavored cherry cough drops or medicines when you're a kid, and somehow I can still taste that in there every time I eat a cherry, even if it's the ripest, freshest, cherry. If it's a chocolate covered cherry, it just, something about the taste just rubs me the wrong way.
Yeah, I'm with you there. Cherries and grapes are not for processing. You have to eat them like, raw, So
it's funny. So I had I got a prescription from my physician for an infection a couple of weeks ago. And it was like one of these things that had like a taste from childhood. And I remembered it. It was like such this, like, I remembered like growing up and like drinking this thing. And it was like bringing back fond memories. So I think like I had some like sweet spot for, whatever that cherry flavored like cough medicine is.
Yeah. Cherries are one of my wife's favorite foods. So, I can buy them for her and she can enjoy them and not worry about me having to refrain from eating them. But she also loves mushrooms, so there you go.
Right.
There you go.
Yeah.
All
right. This has been a fascinating conversation. Thank you again for joining us. And thank you for co-hosting. Wonderful job. And listeners and watchers, I guess. Until next time.
Thanks for having me.
Thanks a lot, Zach.
Thank you for listening to this week's episode of our Curious Amalgam, a competition, consumer protection, data protection, and privacy law podcast. It is produced and shared around the globe by ABA's Antitrust Law Section. The opinions expressed by the participants in this podcast are their own and do not necessarily represent their employer or other organizations. If you like what you heard or would like to become a member of the American Bar Association, please check out what the Antitrust section has to offer at ambar.org/antitrust. You can learn more about our podcast at ourcuriousamalgam.com. If you have comments, suggestions, or podcast ideas, please reach out to us at podcast@ourcuriousamalgam.com. Until next time, thank you for listening.